So I've obviously been given the daunting task of trying to convince a group of surgeons that surgical resection is not the best option. I thank my former fellow classmate Mike D'Angelica for that, whether it was me accepting or him challenging me. I stand up here to try at least to defend that, and I think we can, and I appreciate Dr. Belgetti's extensive research, and we'll go over some of the potential sort of pros and cons. The goals of my presentation are to obviously demonstrate to you, hopefully, that resection in a small lesion is not the optimal initial approach. More importantly, I think it's critical in the next 15 to 20 minutes I can convey to you the understanding of the use of local non-resection based therapies, understand the potential risk and benefits of thermal ablation, and understand some of the initial benefits of using hepatic arterial therapy, which has been utilized in combination for this disease. And then last, which I think is probably the most important point, we as surgeons must begin to better understand the molecular effects of HCC, and I will touch on some of that, which have been driven by surgeons in that regard. I think the preoperative decision-making is essential. The optimal therapy is surgical resection first. The question is obviously, should we either resect or ablate that lesion? Obviously, the key question is what approach is best? It is truly a multifactorial problem. And obviously, I think the key factor within that deciding factor is, do you understand the biology? Which makes HCC even more complex is the bimodal problem, and I'll touch upon that. And then the last thing is obviously, I think, the key question that we all need to evaluate in this disease. It's not can we remove that portion of the liver, or can we do that, but more importantly is obviously should we. And that truly is a complex decision making that is continuing to change monthly with the data that's being presented. I think the backgrounds are obviously the challenges improving HCC. We are doing that. We are obviously establishing the diagnosis earlier. We are seeing a larger subset of patients with less than 2 centimeter lesions, which makes this debate and discussion, I think, all more appropriate. However, there is obviously a lack of universal prognostic staging systems, and by last count, there's upwards to 18 of them that are currently available. More importantly, we do not have a true combination of both prognostic and predictive biomarkers that we can use preoperatively, pre-surgery, or pre-invasive therapy, which I think will further direct which therapy will be optimal. And then last is obviously the HCC stratification. Depends obviously on the accurate prediction of survival and how they present. We are dealing obviously with a bimodal type of process. We are dealing obviously with the underlying biology of the disease, but just as importantly, we are dealing with the underlying frailty of the organ and what it can withstand. There unfortunately is a low level of proof in our surgical specialty. Granted, I understand that we do have some small randomized controlled trials evaluating our therapy, that being surgery. However, we are being quickly dwarfed by the molecular changes and pharma that is obviously being able to generate far more larger and potential level 1 evidence compared to us. I think that is a challenge that obviously we can rise to, and I think one that is important in allowing us to truly define what is the optimal therapy in hepatocellular carcinoma. Because as you all know, it's a truly complex multifactorial problem. That obviously in regards to both the environmental exposure, the genetic distributions that are occurring that are leading to a similar histology, but as you all know, a vastly heterogeneous biology. Within that are obviously the number of staging systems and classifications that we have used. Obviously some of them that take into the patient characteristics, the tumor characteristics, as well as the liver characteristics, with some of them overlapping, some of them being very specifically located to the location of origin, i.e. Italy being different than the U.S., being different than Asia. More importantly, the Northeast being different than the Midwest. These are all, I think, significant prognostic factors that must play into our evaluation and understanding as to which therapy is obviously going to be optimal at which time. Now, we do have a laundry list of local therapies that can be utilized in the management of HCC. The nihilist or skepticist could say, well, the reason we have so many is because none of them work that well. And I think that's possible. However, the optimist, or the one who is obviously focused in the truly multidisciplinary care of this, can understand that each of these therapies provide some advantages, but just as importantly provide some limitations when not used appropriately or with poor technique. Surgical resection, as Dr. Belghetti, has obviously been established for a long period of time, but recurrences, even for small lesions, still relate in the near 50 to 60% range. And that is obviously not a novel concept. We know that simply removing a small lesion does not make the remaining carcinogenic liver better. We've seen that. Intrahepatic recurrences following a section are common. We also know that local regional therapy has been found to be effective in the management. These two prospective randomized controlled trials demonstrating overall survival of conventional TACE versus observation of alone have obviously rendered this therapy as at least an optimal treatment option, but not an optimal versus surgical therapy. If we then look at the meta-analysis from overall conventional TACE, we do see that utilizing a local therapy in patients with small lesions, even in a more advanced Child's B, is efficacious when done appropriately. Now, what about ablation? Now, ablation has been around for a long period of time. There have been a laundry list of authors who have published on the use of ablation, with obviously various significant success rates, all greater than 90%. However, what's most intriguing and, more importantly, most troubling to a group of surgeons such as yourself is the much more wider range of ablation recurrences. If you can see in this column, there are a number of P's that then located to the number of high incidence level of recurrences. Those P's relate to obviously a percutaneous approach. And I must be obviously very definitive that there is an inherent bias in the differences in efficacy of a surgical ablator versus a percutaneous ablator. And let me walk you through that. The reasons for ablation are obviously technique, and I'll demonstrate the significance of that. Location of the lesion also plays a significant problem. We know that getting access to a high segment 7 dome lesion is going to be much harder than obviously a more inferior segment 5 lesion. Technology is a significant limitation and one of the reasons for the wide variation of efficacy in regards to that. We have some technology that is still being used that was initiated in the market in the late 1990s. And then patient factors. Obesity and other comorbidities all play a relative role in the effectiveness of ablation. If you look at obviously the recent prospective randomized controlled trials comparing RF versus resection, you can see here in the non-highlighted, these are majority were done either through an open approach or a combination open and percutaneous approach. The one study demonstrating here the inferiority of RFA was actually a pure percutaneous approach. If you look at the other study that was also pure percutaneous that showed a statistically significant reduction in overall disease-free survival of only 9% at 2 years versus 35% at resection at 2 years, again, another percutaneous only type of trial. And this has been evaluated. A recent study evaluated the use of either surgical resection, surgical ablation versus percutaneous ablation in patients with a similar size hepatocellular carcinoma. And what they found is that the surgical RF group had a statistically significant improvement in overall disease-free survival, and more importantly, had an overall improvement in overall survival compared to the percutaneous. Now, Dr. Belghetti has mentioned the meta-analysis, and obviously this is a robust and a strong evaluation of 8 prospective randomized controlled trials evaluating RFA versus resection. And what this meta-analysis demonstrated was that there was a superiority of ablation in regards to operative and therapeutic complications. with a significant favor of ablation. Not surprisingly, we're doing a slightly less aggressive operation. It makes sense. We will probably induce less morbidity. However, what does it look like in regards to actually operative death and operative mortality? What again we found is that there was an increase in incidence in favor of ablation versus operative mortality versus resection. Similarly, if we also look at 2-year survival rates, again in favor of ablation, and this continues to fall out at both a 3-year survival rate as well as a 5-year survival rates, showing statistical superiority of RF versus resection. Now, obviously the key question in all this is, are all small, less than 2 centimeters or equal, hepatocellular carcinomas the same? Is it really all about size? Are we still at that size realm that we as surgeons are generating risk? And I would probably say to you, hopefully at the end of this, that the answer is no. And what I mean by that is, if we look at the factors affecting overall survival after recurrence, after an ablation, you can see here in this large study with both open as well as surgical ablation performed, none of these predictors of overall survival were related to size. A lot of these had to do, obviously, with the underlying number of nodules as well as the degree of liver injury. Similarly, if you look at another large study, again, the biology of AFP being a significant predictor of overall survival, as well as the underlying liver function, was a predictor of overall survival in these patients with ablation. Ronnie Poon has also published on this in the use of ablation with HCC, and again demonstrated that technical approach, getting a good complete ablation, i.e. getting it all, which obviously is not a novel thing to this audience, but still remains a potential confounder in the interventional radiology who still believes in the debulking kind of concept. And then more importantly, obviously an AFP, having a less significant number, was obviously played a role. Now if we look at obviously the risk of recurrence and resection, again we can find AFP, differentiation, and margin. Again, not about size. And this continues throughout all of the large studies that have looked at hepatitis B and C induced HCCs, and that the risk of recurrence and overall survival is not just about size. So, if we then look at this, what actually is? And we have a number of surgeons who have actually begun to look at this. Shishir Mattel at Emory is obviously began to look at this with both vascular endothelial growth factor receptor as well as platelet-derived growth factor, and I'm going to go through each one of those markers specifically. But so that you understand, obviously vascular epithelial growth factor is obviously very important with the number of receptors, and is obviously the prime receptor that sorafenib, the currently only approved drug on the market, obviously blocks, with a significant reduction in obviously the RAS-MEK pathway, which reduces overall, and as well as reduction in angiogenesis. Sutent, which is another molecular therapy which has not been as robustly active, also works on the similar pathway, but then also blocks the platelet-derived pathway in a much broader type of antagonist. If we look specifically at VEGF expression, what we can find is that VEGF expression has begun to be more correlated to a poorly differentiated lesion and underlying significant satellite lesions, not related to just size alone. If we look at obviously the predictors of RFA, which we have looked at, the predictors of RFA failure related to specifically VEGF alone, serum levels of 250 picograms per ml were a significant factor in correlation to both reduction in platelets, a correlation with reduced platelets, higher VEGF levels, but then more importantly was a significant predictor of tumor progression and failure after RFA, with this curve showing less than 240, this curve showing greater than 240. Again, a potential molecular marker demonstrating where RFA will not be as effective. Now, if we also look at the MD Anderson group that presented this data at GI ASCO in January, they looked at both VEGF as well as IGF and found a significant correlation with low IGF, high VEGF, demonstrating a significant reduction in median disease-free survival with only 3 months when you have that type of exacta of bad molecular markers. This obviously panned out and was found to be one of the most significant factors in disease-free survival, far more so than Child-Pugh and even tumor morphology, and similar to AFP. Again, demonstrating the predictive values of molecular. If we look at another molecular marker, proline-directed protein kinase, again, you will see that significant types of factors, where obviously with multivariate regression analysis in this large study of 134 hepatocellular carcinomas resected, patients who had a reduction in expression had a significantly improvement in overall survival and reduction in recurrence than patients who had an overexpression of this marker. If we then look at the platelet-derived growth factor, and this is the Emory data that he provided me, you can see obviously the effects of the low expression and high expression. And what you can see with the differentiation is that obviously with patients with low VEGF expression, with significant reduction in overall survival significant improvement in survival with low VEGF expression. If you look at platelet-derived growth factor alpha, again, a similar distribution when you have a low versus high expression. And then also platelet-derived growth factor beta, similar types of decreases in survival with higher expression. In their multivariate Cox regression analysis, they then demonstrated that these factors are predictor of overall survival when you compare it to other more established types of predictors. This overall survival remains with both platelet-derived growth factor beta, and then also when you provide them in a combination, again demonstrating the molecular power and the underlying biology that can be understood. And so in summary, I think for a favorable, and we can obviously talk what we define that as, small HCC, RFA is an appropriate technique in the appropriate hands and in the appropriate position with the appropriate technology. Similarly, I think a thorough understanding of all of the facets of the disease and the biology is essential. You can't just think of it as a simple size type of criteria. More alone, I think that obviously size alone is not as powerful of a predictor. I think it was in the past, but we are now seeing a significant progression in the overall understanding of HCC. Obviously, what is a confounder and a challenge to this debate, which we thoroughly acknowledge, is that there is a wide range of heterogeneous biology in HCC. The types of HCCs that are seen in different epidemiologic countries is very different. However, I think the new paradigm shift for HCC management, such that in the past where we required a needle biopsy for diagnosis, is now more a needle biopsy is now established for prognosis to evaluate the molecular markers that can be evaluated prior to any type of definitive therapy. Thank you all.